How to evaluate kidney function? So what are the factors which can affect GFR? Body size and gender. What are the biochemical marker of kidney? Creatinine, because it's an endogenous marker of GFR. How creatinine is produced, I talk about it a little bit. It is produced by the metabolism of creatinine in the muscle, which will produce serum creatinine. And then when we eat protein like meat, that will also produce serum creatinine. Creatinine is freely filtered and reabsorbed by glomerulus, but only 10% can get excreted in proximal convoluted tubule, used as a marker of GFR. What is the marker between GFR and serum creatinine? It's not linear, it's inversely proportional. What are the factors which can affect serum creatinine? Decreased muscle mass, malnutrition, increased muscle mass, end-stage liver disease, chronic kidney disease, medication like Bactrim, cimetidine, and Zosyn. Cimetidine, we discussed about it. Bactrim is an antibiotic. It can affect the serum creatinine level, but GFR will not be affected. Zosyn, same kind of situation. It can affect creatinine level, but then GFR will be the same. You don't have to remember this. But the name of the antibiotic, Zosyn and Bactrim and cimetidine, they can affect the serum creatinine. What is creatinine clearance? Volume of the plasma cleared of the kidney per unit time. Basically, volume of the plasma that is cleared of the kidney per unit time is called creatinine clearance. It is measured by 24-hour urine clearance. Creatinine overestimate GFR because 10% secretion of creatinine in proximal convoluted tubule. We discussed about that. BUN, because we use BUN and creatinine in the hospital as a marker to estimate kidney function. How BUN is produced? By the metabolism of protein, resulting in blood urea nitrogen. BUN is a poor marker of kidney function because it is not produced at a constant rate. And then it is constantly reabsorbed along the tubule. So let's say this is glomerulus, this is Bowman capsule. So let's say the urea is produced, it will be constantly reabsorbed as the urine is moving through the tubule. So it underestimates GFR, but it is only useful to estimate GFR if a patient has end-stage renal disease, especially if the GFR is less than 15. And again, this is not the thing they will ask you when you can use it. They can ask you why it is a poor marker of kidney function, because it is constantly reabsorbed along the tubule as it moves along the tubule. Other method of estimating GFR, you can go over, they will not ask you any question from this. Inulin clearance, cysteine C, Cockcroft-Gault equation to get the corrected GFR. We use this in the hospitals. Take into account lean body weight, age, gender. There are some other equation, MD-RD equation, CKD. You don't have to do this. Next is clearance. Clearance is important. We will discuss different clearance of substances. So what is clearance? The volume of the plasma from which the substance is removed over the period of time. The volume of the plasma from which any substance is removed over a period of time is called clearance. How we calculate clearance? U into V over P. What is U? Urine concentration of a substance. P is plasma concentration of a substance, and then urine flow rate. So urine flow rate they will always give you, always given in the question, and then you will be calculated, and they will give you the level of urine concentration of a substance and then plasma concentration of the substance. So what is inulin clearance? So inulin is a polysaccharide that is used to measure GFR. It is neither reabsorbed nor secreted. So we can see the exact GFR and filtration fraction. Glucose is filtered and then reabsorbed. What is transport maximum? This is an important concept we need to learn here. So nephron, for the nephron, there is a maximum concentration that they can be reabsorbed for the glucose. So let's say the glucose level is increasing. There is a capacity glucose can be reabsorbed by the kidney, and once that capacity is lost, when the glucose is still high above that number, then it will not be reabsorbed. It will start appearing in the urine. And the transport maximum for glucose is 300 milligram per deciliter. So if the concentration rise above 300 milligram per deciliter, glucosuria will appear. What about protein? The large and negatively protein are basically large and negatively charged molecule. So they are not even filtered. So they simply run through and move on to peritubular capillaries, because we know that glomerular basement membrane has filtration as size and charge barrier. So the protein will not be filtered. Para-aminohippuric acid. So it will be filtered into the Bowman space, and then it will be secreted by the proximal tubule via carrier-mediated organic acid active transport. It will not be reabsorbed by any portion of the nephron. Therefore, the luminal concentration of paramedic acid progressively increase, because it is not reabsorbing. We will not reabsorb it. So it will continue to increase throughout the nephron. The point at which the paramedic acid is filtered into the Bowman capsule is going to be the lowest concentration at any point. But after that, we constantly see increase in its concentration due to secretion along the rest of the tubule. And this is one of the reasons that para-aminohippuric acid can be used as a marker for renal plasma flow, because the blood is moving into the glomerulus and leaving, because initially the concentration is so low that it is only filtered at the lowest level, at the level of glomerulus. So it can truly assess renal plasma flow right there.